Good morning, good afternoon, good evening, wherever you may be. And today we are having a conversation with one of our MPN specialists, in this case, Dr. Aaron Gerds from the Cleveland Clinic. And many of you know him and have seen him on one of our webinars. But today we're going to talk about, as well as your questions, we're going to talk about any significant changes in the MPN community over the summer months, because we take this long break typically in the summer. So Aaron, welcome, and thank you very much for the time.
Well, thanks a lot, Ann. It's a pleasure to be with all of you today.
Great. So what happened over the summer? I mean, we're keeping track of everything here, but can you tell us anything that, was significant?
Well, I think I would start off by adding that my Cleveland Guardians yet blew another season. And are heading for not the postseason. But beyond that, I mean, more seriously though, in the summer we have two big kind of medical meetings within the world of hematology and oncology. One is the ASCO meeting, the American Society of Clinical Oncology, which happens in Chicago in June. And usually a week later is the European Society of Hematology meeting that happens in Europe, and was in Milan this year. At both meetings, there were a couple of really big presentations that included MPNs, and quite a notable year, right? Often ASCO does not feature much by the way of MPNs. There's usually a few posters, but beyond that, not a lot of top line presentations. And then for EHA, we had notable MPN presentations in the two biggest sessions. One, the plenary session, which is kind of like the top abstracts of all the ones submitted, and then one in a late breaking abstract that was really kind of important. And this is in addition to all the other data that was presented. A lot of updates on various clinical trials that are ongoing, some really insightful retrospective analyses that were completed as well.
Mm-hmm. That's great. And as far as the clinical trials, can you highlight maybe a couple of those that are
Yeah.
showing real promise?
So I would say the big three out of the summer meetings were the results from the rusfertide randomized phase 3 trial that was presented at ASPRO by Dr. Kuykendall, and really showed that in a randomized prospective manner against a valid comparator arm, that rusfertide did what we expected it to do, right? It eliminated the need for phlebotomies in patients with polycythemia vera,
Right.
whether they were just on phlebotomies alone or whether they were already on a cytoreductive agent. And probably is equally as important, no new safety signals emerged, at least with the initial data. Now, there'll be updated data, of course, in the December meeting in Orlando at the ASH annual meeting, and so on and so forth. But this is kind of the first peek at the data from that pivotal trial. And of course, that's a registration study. We call this in the business a registration study because they would use this data as kind of the pivotal piece for a registration or a new drug application with the regulatory authorities, the FDA and the EMA. So it's a pivotal registration study and a first kind of glimpse at the results from that.
It's great.
And then the two studies I think that were kind of top of the list over at the European meeting were the results, first of all, in the plenary session of a prospective randomized trial in essential thrombocythemia. We don't have a lot of prospective randomized trials in ET, so it was really nice to see a study get across the finish line, if you will, in terms of enrolling patients and then starting to get results. And this was a trial in the second line setting, so patients who had already received hydroxyurea for their ET. And in that trial, patients were randomized either between ropeg interferon, which many of you may be familiar with, but this is kind of developing that data that we all expect it to work because we have a lot of experience with Pegasus and other interferons, but developing that specifically with ropeg. So it's ropeg interferon versus anagrelide. Now, anagrelide is useful in some situations, but it's not a perfect drug by any stretch of the imagination. And some may even go to the extent of calling it much maligned, but it definitely is a commonly used second line therapy. So it was a reasonable comparator arm in that trial. And I think kind of the take home point from that study was in almost every measurable way, ropeg interferon outperformed anagrelide in that setting. It doesn't answer the questions of what's the best first line therapy. It doesn't answer the question of like long term. There's no long term data with this, of course, because it's just the initial results. It doesn't say what happens in 5 years, 10 years, 20 years down the road with patients who are on ropeg, but it certainly shows that pound for pound, ropeg did a pretty darn good job controlling counts. Pound for pound had a really good side effect profile and is a reasonable alternative to anagrelide, or arguably a better alternative to anagrelide in the second line setting. The third kind of big study that came out this summer, the second one from the European meeting, was a late breaking abstract. So late breaking abstracts, just to let you all know, is so there's a normal abstract process. The call for abstracts opens up usually around January, February, with a deadline there, and you got to get them all in. But something may happen in that interim before the meeting. So a few months later, there's usually this call for late breaking abstracts. It's almost often clinical trial data. And that's what this case is. Now, it was the initial results from the calreticulin mutant-specific monoclonal antibody study. So calreticulin is a little unique compared to JAK2 and MPL mutations that drive MPNs because it's actually external to the cell. It's outside. So you can actually get at it with some treatments that need to physically touch the molecule that are also big molecules in themselves. So an antibody is a really, really big molecule. So it can't get inside of cells to affect change. But the fact that the reticulin mutated proteins on the outside, you can actually get at it. And so this antibody kind of clips on to the mutant calreticulin protein, disrupts that interaction between the different receptors there, and then and cuts off that downstream signaling. Also, we have lots of monoclonal antibodies. It's a fully humanized antibody. It's almost like a very natural substance, if you will. And so we would anticipate the side effects to be quite minimal from this. So that's why I think it's a very exciting therapy, because it's unique and we would anticipate the side effects to be quite minimal. And in fact, that's what we saw in this initial result. First and foremost is, since it's an early study, the safety profile takes priority. And the safety profile was what we expect, that people did overall quite well on this medication. There weren't any unanticipated side effects that we observed. Of course, a few allergic reactions, a few other kind of things happened, but quite minimal. Secondly, we get an early glimpse into what the efficacy may be, and reported out was a 70% response rate with this medication, which is pretty exciting. Now, early data, there's also a little hint that it might do allele burden reductions, although again, very early on, too early to tell what that will fully look like with more time, but definitely some really interesting data. And probably the most important take home from that abstract is, again, no unexpected safety signals.
It's fantastic. God, I'm telling you, since 2004, 2005, when I entered this
Yeah.
arena, I mean, it has not stopped. It has just not stopped. And it's just fascinating and wonderful. It's just wonderful. So I have some questions for you,
Yeah.
as you know. And one of them is, you mentioned interferon, and some people would like to know, is that now kind of a protocol that you recommend instead of hydroxyurea or ruxolitinib? What is it that prompts you to suggest interferon? And we're hearing a lot about, we have a huge database of young people with an MPN, mostly ET and PV. And many of them are on an interferon and were
Yeah.
started on an interferon. Is that pretty much your protocol as well?
Yeah, it depends on the situation, right? And every patient's different. I think you start with a principle of two things. One, what are you trying to achieve with your treatment as an individual patient, right? And it depends on what your goals are and what you're comfortable with doing. And so you look at each of the treatments. For the first line therapy, for PV and for ET, if you kind of look at guidelines and you kind of look at everybody's everyday practice, we almost put, certainly for younger patients, hydroxyurea and interferons kind of like almost on equal footing. Maybe a
Mhm.
little here, a little there, depending on the student. But in general, most people kind of put those as equals. The MPN RC112 study clearly showed in ET and PV in the frontline setting that they were equivalent. So we're quite comfortable doing that. And again, if you look at things like the NCCN guidelines, it will reinforce that kind of principle that interferons and hydroxyurea are on equal footing for first-line treatment. So if they're an equal footing, then you start to say, well, what are some more specific details that could push us one way or the other? Potential side effects, correct, would be one of them. And so like if I have a patient who has, a lot of sun exposure and has already got a bunch of actinic keratoses, these kind of precancerous skin lesions, maybe hydroxyurea isn't the best choice for them because it can make those worse and they could have a lot of dermatologic surgeries coming up. On the other hand, if I have a patient who said, we're thinking about things, which one should we choose? And they may have an autoimmune disorder. maybe I'll steer away from interferons for that individual. So we do look at side effect profiles as well.
Right.
And then the last layer is, well, what are the ultimate goals? There are lots of patients who go out there and, they'll read up on their disease, and they'll learn about allele burden reductions and understand some of the uncertainty long term with that. What does it all mean? What if I don't get there? And all these other kind of questions that come up, but kind of understand that principle and say, hey, I think this might be the direction I want to go. And some patients will come in and say, you know what, I read about it. There's no way in God's green earth I ever want to stick a needle in me. I won't be able to do that, and I want to do pills, right? Um, and then the fourth layer, unfortunately, is insurance. I think it's the third rail, if I can use the Chicago term, in
Yes.
every treatment decision. And a lot of times we meaning the doc and the patient will sit down and come up with a treatment plan, but the third rail will say no, and we have to navigate that as well. And unfortunately, sometimes that drives treatment decisions as well.
And that is a very sad statement,
Yeah.
very sad statement. And so, if you are a patient listening to this and are in that situation, please let us know, because the treatments that are available, almost all of those companies, I think all four of them,
Yeah.
definitely have a program that may enable you to get the drug that your physician would like you to try or take, and you've been having problems with your insurance company. Just breaks my heart. But anyway, you mentioned skin lesions and so on, and this patient actually has been on ruxolitinib for quite a while and has had four Mohs treatments, and processes, where they cut the skin out and cut the mole out or whatever. And so, would you suggest, now that there are other um, drugs in the market, would you
Yeah.
suggest that person that is having trouble with skin lesions to to transition to another drug?
Yeah, I mean, I think you have to take the whole clinical situation into account, right? If it's someone who has like a known predisposition or has had a lot of sun exposure, even switching may not help that. You can always take a break for a while and see if the velocity of these things change as well, and you can always go back. So there is a lot of flexibility in that thought. But yeah, I mean, I definitely have had patients where we put them on hydroxyurea, and all of a sudden these things just start blooming. It could be coincidence, but boy, I mean, the temporality there really suggests otherwise. And so we do say, okay, this is not going, like, we don't want you have to visit your dermatologist every 2 weeks to get things lopped off constantly. Let's pivot and think about a different treatment. I think one of the tricky parts is we talk about this for hydroxyurea, but ruxolitinib carries a similar risk, right? And although they're completely different drugs, and we think this thing happened by different mechanisms, sometimes changing from hydroxyurea to Rux or Rux to hydroxyurea doesn't always help the situation. Although they are different drugs, and sometimes it does. So I think that really kind of gets to the art of medicine, right? It's not a pure science. We're not engineers here. There's not pure numbers, pure science, and so we do have to have a little bit of that art. Look at the situation, try to interpret what we know and what we don't know to make the best decisions possible. But the important thing at the end is that these decisions are fluid, right? We can always go back. Just because you make a choice, let's try this now, doesn't mean we're locked in and we can't change course if we need to.
Hmm. So, at another conference, an in-person conference that we held recently, one of the MPN specialists talked about hydroxyurea, and we know tons of patients that are on hydroxyurea still with the other drugs that have been commercialized. And she mentioned that she was just not prescribing hydroxyurea as much. Would you say you have kind of gotten to that point as well, with the other drugs available, or do you still feel like hydroxyurea is a good drug that works for a
Yeah,
lot of people? And
absolutely. I think there are some clear advantages to hydroxyurea, right? I think the route of administration is pretty straightforward. Right? You just take a pill every day. It is widely available. You can go to any pharmacy down the street, pick it up, right? You don't have to work with a specialty pharmacy. There's really no drug shortages for hydroxyurea either. From a systems-based approach, when we talk about value in healthcare, it is relatively inexpensive. And, in large part, the trials have shown, equal or at least near count control compared to other very available therapies. But on the other hand, it's not a perfect drug either. It doesn't work for everyone. It doesn't always achieve that basic goal of controlling the counts. It obviously can be associated with side effects, and to the best of our knowledge, doesn't really deeply alter the course of disease. It can alter the course of disease by controlling the counts, and first and foremost, that's a basic principle of treating when we're using these medications. But it doesn't, the whole allele burden story and the connections that we're starting to make there with that, it has minimal impact on that, if any at all. And so that's why we do pivot and really honestly think about things like interferons and ruxolitinib in patients with PV and ET.
Mhm. It's so funny whenever we talk about allele burden now.
Yeah.
And I remember years ago in some of the events that we hosted and people saying, does my allele burden have anything to do with how I feel in my MPN? And the answer was equivocally, no, you're fine. It's not, it don't even think about your allele burden. And in fact, we do need to think about it. But anyway, moving on. This question is about Mediterranean diet, supplements, and what your feelings are about that. And this person is on ruxolitinib. They are taking vitamin B supplements and have been a vegan for quite a while. I think I might be mixing these up. Yep. And but she or he has noticed a trending of their hemoglobin is going down. And can you address that at all? I mean, is there any evidence that not getting enough protein perhaps or something on that in that way?
Yeah. Of course, there's quite a few things here to
Yeah.
consider. Kind of work through them one by one. I question I get all the time is like, well, what can I do? You know, you do the blood work, you do the labs, you talk about the medication, but doc, what can I do specifically to help myself? And we start with common sense things because common sense are common sense because they make sense and they've been around for a while and they actually work, right? So common sense stuff when exercise, right? And take it's part of taking care of yourself. We could treat the myelofibrosis to beat the band or the PV or the ET, but if you don't take care of the rest of your body, your cardiovascular health, your kidneys, your liver, those things could potentially fail as well. And then that makes the treating the myelofibrosis or the PV or ET much more difficult. So taking care of yourself includes regular exercise for that cardiovascular health, the mental well-being, and there are basic data. Again, it's not huge prospective randomized trials, but there are data that exists that regular routine exercise does improve symptoms with myelofibrosis. And it actually makes a lot of biologic sense, and certainly exercise is not going to be harmful. The next thing we always talk about in terms of like self-care would be diet, right? I certainly don't advocate the getting Wendy's every Thursday night kind of diet. That's probably not a super healthy thing. But sometimes the mental benefit from splurging dietary wise every once in a while is probably not a bad thing. But a good healthy diet I think is important. There's quite a bit of data emerging, and that have been reported on the Mediterranean diet, not just in MPNs, but in general. Particularly in the cardiovascular world, there's quite a bit of data showing that the anti-inflammatory effects of the Mediterranean diet and how it can be beneficial for your heart health. And that's a big consequence for patients with MPNs. We all know that people in general have a risk for heart attack and stroke, just again, the general public, right? If you have an MPN, that risk goes up. It's additive. So anything we can do to bring that down, I think is a good thing. So yeah, a patient asked me, well, what diet should I do? I said, well, there are data that suggests that Mediterranean diet can actually be quite beneficial, both in the MPN world and outside the MPN world. There was that randomized pilot study back in 2022 that kind of showed some preliminary evidence in MPN specifically that the Mediterranean diet can be beneficial. But I definitely think that is a good thing to do. Certainly, it's not harmful, right? And if you like olive oil and fish, all the better. Um,
I do.
talking to an interventional cardiologist about this one time, and really the big focus was like eliminating the red meat, right? That's the big part of the Mediterranean diets. No red meat more than once a month, kind of a thing. So if you want to kind of ultra simplify the Mediterranean diet down, it's just eat red meat no more than once a month, and kind of work from there. I mean, obviously, the full Mediterranean diet, there's a lot more to it, but that's just an overly simplified version of it. And then after that, well, I think the data start to get pretty thin in terms of lifestyle modifications after that. There are some suggestions that other diets may be beneficial, other types of exercise specifically. The data on supplements, to be honest, is kind of all over the map, right? Some say yep, some say no. Patients have a lot of anecdotal experience, say, hey, I've tried this supplement, it makes me feel better. Other patients have tried it and said, no, it doesn't really help me at all. Without good, rigorous studies with a lot of supplements, it's going to be really hard to say. The practical advice I give patients is, let's talk about it ahead of time. Let's first make sure there's no known safety issue. If there's no known safety issue, try it. If after a month or 2 months you feel better, great, continue. If not, then let's not waste our time and money, right? And let's kind of scale it and move on to something else. So, without data, we try to take a very practical approach to things. And then the vegan angle in particular. So veganism is the one kind of challenge in any type of bone marrow situation will be the fact that in a vegan diet, there's really no B12, right? So you have to supplement with adequate levels of B12, usually taking a B12 tablet. Sometimes if the gut's not absorbing properly, B12 shots even. So keeping up on that B12 level is important. And then in part with like making sure that the diet is still well balanced and you're getting all the micronutrients that you need. So there's a little bit more work to veganism than there would be to some of these other diets. It doesn't take much B12, but definitely you have to take it in order to kind of maintain good blood production.
And if the person sees their hemoglobin trending down, doing these things, would you suggest more protein? Would you suggest
Yeah.
there's something else going on, or
Yeah, I think, I wouldn't empirically recommend anything necessarily, but saying, well, why is the hemoglobin down? That's again, the place I would start. Instead of just putting a topical band-aid on it, let's get to the root cause of why we think it. Is it the disease? Is it the treatment? Is it something completely unrelated, like a B12, right? And we can simply check B12 levels. We can look at iron studies. We can look at even some iron parameters to see if there's like an iron homeostasis component to it. So there's all these pieces we can look at to try to understand where we should go.
okay. Let's see. We have other questions here. This is a PV patient. They were diagnosed 9 years ago. They're very
Mm-hmm.
symptomatic. No MPN specialists available, which is pretty much the majority of the people we work with. They live in Las Vegas. They do get phlebotomies. They're not able to tolerate hydroxyurea. The hematologist that this person does see is irritated because they're hesitant to try new medications.
Mm-hmm.
Their spleen is at 18 centimeters, the liver's at 20 centimeters. The hematologist said, no surgeon will touch me. I'm in a panic. Is this true? I'm not with my doctor. I don't know what that means, but anyway.
Well, it's hard to say without all, having kind of everything in front of my face here, but
Yeah, and
um,
I know you can't answer this.
oh yeah, yeah. So if I had a patient similar to this sitting in front of me, I think the first thing was, categorizing or cataloging, if you will, the symptoms that they're having. Are they more cytokine mediated symptoms? Are they related to the spleen being enlarged? Let's kind of get some granular detail to what those symptoms may be, and that may help guide us to where to go. I think the other piece of the puzzle is, where is their MPN right now? Is their MPN kind of firmly good old kind of proliferative PV? Is it somewhere in transition to myelofibrosis? What other clues are there that we may want to round out the picture? Ultimately, if a patient with PV is that symptomatic, and hydroxyurea is not improving their symptoms, then that's not working for them, right? And if you look at any guidelines, again, pointing to the NCCN guidelines, that is an indication to change treatment. And at that point, you're really looking at interferons and ruxolitinib. And if a person's very symptomatic, we tend to lean more towards ruxolitinib, particularly if it's cytokine-mediated symptoms or spleen-mediated symptoms, because those can be made better by ruxolitinib in a much quicker manner than, say, interferon. Interferon might take a while to get there.
Yeah.
And then bolstered by the magic PV data that showed that kind of an unexpected number of patients had molecular responses, and those that did had very good long-term outcomes. Yeah, I would consider a change at that point in a patient in a similar situation who is very symptomatic. Maybe their counts are controlled, or even not, or even if they are controlled on hydroxyurea, but they're still that symptomatic, that is a reason to pivot to another therapy. And I think out of the two, if it's a symptomatic patient, ruxolitinib is pretty high on the list.
Yeah, I would say so. I mean, I'm not a physician, but it
Yeah.
sounds like it. At what point do you evaluate the effectiveness of Pegasus for ET in terms of decreasing the allele burden and for molecular remission?
Yeah, that's a million-dollar question, to be
Yeah,
honest. If we look at a lot of the studies that have been done, not a lot, some responses occur pretty early on, but really, 2 years seems to be a pretty good place to check. Responses can happen within the first year and certainly within the second year. But at 2 years, most patients who are going to have a decent response will have had so by then. So I think checking any earlier than 2 years after initiating interferon therapy, you might get a clue, but it might not be everything, right? And so I would say at least 2 years out. And then after that, it kind of depends on where you are and what the goals of the treatment are. Certainly, I don't advocate for doing it more than once a year, unless some clinical change, situations are rapidly changing. More than once a year, you're probably going to get a lot of noise in those signals, and there's a good chance that insurance may not pay for it. That's the other kind of key. So we have to again remember that third rail in medicine of insurance, and not to incur too much, hazard to our patients and financially. But the NCCN guidelines have reflected a lot of these kind of thinking, the thinking in the field with allele burden. And it used to be kind of a hard no, do not check allele burden on treatment. We don't know what to do with it, just don't check it. It's research only. But now it's kind of come around. And if you look at the kind of fine print language, it's like, yeah, if you're kind of thinking about things, go ahead and check it. There may be some utility in that. So even like, guidelines are softening on this, which will hopefully again help with that third rail somewhat, but also hopefully help guide practitioners to considering checking allele burden to see and having those conversations with the patient.
right, absolutely. This person has had PV for 25 years. They are on Jakafi, and is there any benefit for them now, after all these years, to have another genomic test, just to see where they are at this point?
Yeah. I mean, 25 years. So the testing 25 years ago was not what it is today. At a minimum, I think every patient needs a next generation sequencing panel where we look at multiple genes. It helps with understanding, obviously, the genomic landscape of the disease, but can help with prognosis, can identify potential therapeutic targets, can establish a baseline where you are today. And then if there's a clinical change later on, you have something to compare against, right? Was there genomic evolution of the disease over a given interval? So at a minimum, if that hasn't been done yet, that's kind of a pretty straightforward answer. If there's no multi-gene panel, I would recommend that. A lot of times with if you are on a therapy we think can influence allele burden, it would be nice to understand where you are, where you stand with things. It may explain how well or not well a patient's feeling or how far they've come on their treatment.
Wow, and that's a great answer. This person was on Besremi and failed, did not work for them. Now they're on ruxolitinib, even
Yeah.
though they've had skin cancers in the past. They were on HU for quite a while and had numerous squamous cell skin cancers. Is the reaction they had from Besremi common? They had extreme itching. I've not heard.
Oh, yeah. I've had a couple patients on interferons have some extreme itching. It's not a common side effect, I would say, but definitely can happen. Um, there are a lot of these kind of unusual side effects that occur with medications, and sometimes it's hard to pick, right? I think the alternative explanation would be, well, maybe the interferon didn't help their itchiness that was part of their PV, and ruxolitinib did now.
Yeah.
It's really hard to say. The only way to truly know is like you start the interferon, the itchiness happens, then you stop the interferon, the itchiness goes away, and you restart the interferon, and the itchiness comes back. That would be the best way to understand if that's a side effect, but that's not always practical, right? You don't want people suffering and getting itchiness and not getting their treatment. So it makes more sense to do the interferon if you're having a side effect than just switch to ruxolitinib in this case. Um, but that I have seen that in a couple of patients though as a side
Yeah,
effect.
it's interesting because I remember years ago sitting at my desk getting a call from a gentleman in San Diego, and he had PV, and he said, I am going crazy. The itching is horrible.
Yeah,
There was nothing on the market, nothing. And there was no, I mean, there was nothing anywhere, anywhere we searched, we couldn't find any help. And he said, I cannot wait to have MF so I can get a stem cell transplant. Isn't that awful? And
and that it's
hopefully
crazy.
he was still around when these drugs became available, because I know it can be very, very awful for some
Mhm.
patients. Let's see here. Does ruxolitinib help lower allele burden as well as interferons? they've taken Rux for 3 years and their allele burden has increased from 60 to 72%.
Yeah. Yeah, I think the short answer is we don't know because there's not a large prospective randomized trial comparing interferons to ruxolitinib with the specific intent of looking at allele burden differences. So we're doing cross-study comparisons, which is not always the best thing to do, right? There can be a lot of biases and untoward statistical variations that can be introduced in that kind of preposition. So, but what I can say from some more recent studies, again, like Magic PV, there was a higher than anticipated number of patients who had a reduction in their allele burden on that study, at least higher than what I would anticipate. And again, those allele burden reductions were correlated with better long-term outcomes for those patients. So I think most importantly from that Magic PV trial, we are linking allele burden reductions with better long-term outcomes and starting to in a consistent manner. And I think in a prospective manner too, which I think is incredibly important. How reliably ruxolitinib does it, I think is still a question mark, right? Because that was one smaller randomized phase 2 trial. There's not consistent data study over study to really kind of come up with a number. Of course, there's no comparison with interferons. But again, that's kind of like next level, right? So when I kind of think of, I don't know, I don't have a good analogy for this, but it's almost like the opposite of Dante's Inferno. Like there's the levels you go down in hell in Dante's
Right.
Inferno. It's the opposite, the levels of benefit as you go up with these drugs. And first and foremost, especially for patients with PV, are we doing the basics, right? Are we doing the daily aspirin or some sort of antiplatelet therapy? Plus, are we keeping the hematocrit under 45%? I mean, that's the ground level. That's what we need to do at a minimum. And if the ruxolitinib is doing that for a patient, that's great. We're achieving that basic goal. The next goal, or I would say a partner goal with that is symptoms, right? Are the symptoms and spleen controlled? And if we're yes across the board, then I don't think there's a compelling reason to change therapy in a patient who's on ruxolitinib for PV. Allele burden, yeah, that's great. I'm glad we're checking. I'm glad we're learning more about that. But it's a minority of patients who have allele burden reductions, both on interferons and on ruxolitinib. It's not the majority of patients. And just because the allele burden hasn't gone down doesn't mean you can't enjoy long-term benefit from a medication like that.
Right.
And so I think it's a tricky wicket, and it's a higher level. You're achieving the basic principles of treatment, and these are kind of added maybe benefits, but I don't think a rigorous indication to change what you're doing necessarily.
Yeah. Aaron, you've been practicing for a long time now, and I've been around forever. And so what are you seeing now? Like when you diagnose a new MPN patient, are they younger? Are you seeing, because we're hearing a lot from
Yeah,
young patients, and I'm saying, not only pediatric, but 18 to 30 or
yeah.
30. Um, are you seeing patients coming in immediately with a lot of symptoms, or I mean, what is your average day like?
Yeah,
When
yeah.
you
It's a little tricky, being a referral center. So we're not kind of on the front lines necessarily every day as you would think, but I've definitely noticed trends of younger patients. I don't have any hard data for that, but it does seem like people are getting younger when maybe that's because I'm getting older and older. It's a relative time
could
point, I
be
suppose.
that.
Could be everyone is technically younger. But some unusual cases. Again, anecdote is not data, but you see patients with even in their 20s and 30s with myelofibrosis. It's kind of like gets your attention a little bit. I would say more and more patients are found with like routine blood work, and fewer patients are coming in symptomatic. And I think between the two, maybe more younger patients being identified, more patients being asymptomatic, we're seeing a shift in disease risk, right? So instead of patients coming in with, say, intermediate 2 or high risk disease, newly diagnosed myelofibrosis, I think we're seeing a lot more low risk, intermediate 1. And the challenging part is this is now trickling into our clinical trials too, right? Because we all see patients and we would say, okay, clinical trials is the way to go. Let's get you on a study. And I think trials like Manifest 2 have succumbed to that. So dreaming up Manifest 2, we think, okay, there would be mostly higher risk patients. We wouldn't have to wait that long for an answer in terms of long-term, survival type benefits. And then it turns out, we enrolled a boatload of intermediate one patients who are going to have a longer predicted survival. And so it's going to be really hard to follow them up for these survival endpoints. And that was, I think, a kind of an unexpected turn with that study. Because again, you get the sense that patients are younger at diagnosis now and are more asymptomatic, primarily because our detection levels are better. Our detection, tools are better.
Yeah, yeah. Okay, this patient read an article about Dr. Chena. Am I saying that name right? At Cleveland Clinic, and it said the GLP-1 agnost I can't read this, may benefit PV as far as slowing progression. And I was going to talk to you about progression because there's
Yeah,
several studies going on right now, looking at progression and looking at the genome sequencing of patients and being able to identify which patient will progress and which one will not, which I think
yeah,
is explosive news. And nobody's really talking about it much. But
yeah,
what are you seeing in terms of progression? We have a ton of ET patients, a ton of PV patients, a ton of MF patients. And I'm not hearing as often the progression from MF to AML. I mean, I know it'll happen. I know it can happen.
yeah.
It doesn't always, but what are you seeing in terms of progression?
Yeah, I think that's the tricky part about MPNs, right? If you look at a disease like, say, let's use lymphoma, for example. Progression's pretty straightforward, right? You put someone on chemo for lymphoma, their lymphoma goes away, and it's like not detectable for a while, then all of a sudden comes back. That's a relapse, right? And then also with lymphoma, like if you give someone chemotherapy and it grows, that's a progression. It's pretty black and white. It's a very simple construct, but in MPNs, it's more nebulous than that, right? You can progress in a lot of different ways. Patients can progress, as you mentioned, going from chronic phase to accelerated or blast phase as those blasts kind of creep up, those most immature white blood cells. A patient can progress in terms of symptoms. Their symptoms were fine given the current treatment regimen, but now their symptoms have returned. The blood counts may be exactly the same, the blasts are fine, but the symptom progression, right? You can have spleen progression. The spleen was controlled with the JAK inhibitor, but now is much bigger. And then you can have bone marrow failure progression, where the bone marrow becomes sicker and sicker and sicker over time and can't make blood anymore. In PV and ET, we can see a kind of a reverse phenomenon where there's progression of the blood counts getting too high, right? So a patient's been on a therapy, say for PV, and their hematocrits come in under good control, and all of a sudden over time, it ain't cutting it anymore, and they're starting to have to need to get phlebotomies or consider switching therapies. So I've just rattled off a whole bunch of different ways that the disease can progress, right? And that makes it really difficult when you talk about just progression in general. You really have to kind of almost hammer down, like, well, what type of progression are we talking about? Now, the first one you mentioned, the progression to accelerated blast phase, which is akin to acute leukemia. We know that certain things really predict that, right? High white counts, other count abnormalities, the blast kind of creeping up on us. But we always pivot to cytogenetic abnormalities and gene mutations, really kind of be strong predictors for that. They're not perfect. I mean, I definitely have patients with very bland genomes inside their disease, and they progress. And there are some patients who have every known genetic risk factor for progression and nothing ever happens, right? These things aren't perfect sciences. They just kind of perk our ears, if you will. And I kind of liken it to, like, it's not a prophecy. It's a predictor. And so it kind of heightens our awareness, right? And someone who's kind of lower risk genomically in terms of their disease for that type of progression, if some things are changing clinically, I'm maybe a little bit more conservative. I'm holding back a little bit more instead of jumping in, like investigating, trying to get to things. But if someone's a high risk for that type of progression, if there's subtle changes, we're making an action really quickly. I think transplant's the big one, right? So someone who's like lower risk and their blasts are kind of creeping up a little, maybe you hold back a little bit more, but someone who's higher risk and their blasts go from, like, say 3 to 5%, I'm like, okay, this is time. We need to do this before it gets the cow gets out of the barn and we can't get it back in again.
And that was the next question
Yeah.
when do you suggest uh, bone
But
marrow cell transplant? That's the big question of the day, right?
Oh yeah, yeah. And that's a hard one. Because everybody's different, right? We're
Yes.
all snowflakes. Everyone's unique. Everyone's disease is unique. Everyone's physical status is unique. Everyone's life view, life experiences, and desires for their treatment is different. And so, as many people are, there's twice as many different right times for transplant. And so to me, the important thing is an ongoing dialogue between you and your doc saying, hey, this is where are we now? And how does that fit with my treatment goals? Obviously, you don't want that window to close, right? There's the whole Goldilocks proposition where you don't want to do transplant too early, where you're risking good quality and quantity of life, but you don't want to wait too late to where there's less likely chance of success. There's that kind of sweet in the middle spot you're shooting for.
Mhm.
Kind of if we want to get statistical and algorithmic, you know, not just for myelofibrosis, but for pretty much any myeloid disorder or any disorder you might do an allotransplant for, 5 years seems to be the magic number. If a patient has a predicted survival on average of greater than 5 years, transplant doesn't do as well. There's increased morbidity, mortality introduced from the procedure. But if the predicted survival without a transplant is less than 5 years on average, then transplant starts to win and start in the long run has a better long-term outcome. So as a rule of thumb, that's a good place to start. Now we can get more granular with DIPS and MIPS and GIPS and all these other models that we have, and like the Gallon analysis that was published a few years ago now. But as a rule of thumb, that's a good place to start. And again, you combine that with, well, what is the donor situation? What is the caregiver situation? Is this the right time for that individual based on their health status, their social status, their disease status? And it's an ongoing conversation. I think for any patient with myelofibrosis, get a transplant consult, get your HLA typing done, put it in your back pocket, right? Just because you go to Midas doesn't mean you need to get your oil changed.
Yeah.
But it's good to have these things kind of prepared and ready in case you need them, right? You're kind of plugged in already. I have plenty of patients we've done that for, and we don't use it, right? And that's okay. And it's fine too if you haven't met with a transplanter and you need a transplant, we can hustle through that. But it's nice to save that kind of that time. You meet with the transplanter, you get the information about what's the process like, what can I potentially expect with this, and even though it's not the right time for me right now, having that reassurance that we've laid some groundwork in case we do need to reach for it in the future.
Yeah, great advice. This person was recently diagnosed with ET, is on hydroxyurea. Their platelets are at 46.5 or 465, sorry.
Ah,
If my level, I'm reading from someone else's writing here, and I'm not doing a very good job of that. If my levels are low, does that mean I should not have symptoms? I have a large bruise on my ankle. Could it be ET?
yeah, that's a great question. Sometimes in patients there is a connection between platelet count levels and symptom burden. Sometimes there isn't. We definitely have patients who are on treatment and their platelet counts look great, and they still have some symptoms that we associate with their ET. So it's not always a perfect match. In general, that does happen. Patients whose disease is out of control, we bring it back down, they feel better, but it's not a perfect one for sure. And so again, you got to take every case as it comes. In terms of the bruising, well, we know that there's a couple of reasons that patients with MPNs can get bruising. Um, One is the fact that patients with MPNs, their platelets may not be normal in number, but they may not be functioning normally. There's this thing called intrinsic platelet defects that can occur. So you could have a platelet count of 446, but still get bruises. Uh, Often our patients are on aspirin or some other antiplatelet agent, or even blood thinners, and that can all increase the risk of bruising. Uh, you know, Although we talked earlier about how patients are seemingly getting younger and younger when diagnosed with MPNs, there are still patients who are older. And as we get older, we start to lose some of that connective tissue in our skin and making the vessels less supported. And it has a very unfortunate name. It's called senile ecchymosis or senile petechia. I did not name this entity, but it's really a loss of that connective tissue in the skin with aging that can increase bruising. So all these things can act together. There may be other medications that lead to increased bruising on top of it, such as some antidepressants can increase the risk of bruising. So you take each of these things by themselves may not be a big thing, but they stack up in a given individual that can lead to the bruising. The important thing is serious bleeding happening. Uncontrollable nose bleeding. Heavy periods in young women. Are the patient having rectal bleeding, or obviously worry about bleeding in the brain? So is it serious bleeding? Very significant life altering bleeding, or is it more kind of the bruises that occur on the tops of the arms and on the shins, and kind of teasing out the bruising and bleeding
Right.
symptoms that one may have.
So we have a time for a few more questions. I have to go back to this GLP-1 question.
Yeah.
Dr. Chenna do you know who I'm talking about? Chenna, who's conducting a clinical study at Cleveland
Hmm.
Clinic. And is that an ongoing in MPNs? It's the
Yeah.
yeah. Can you speak to that a little bit? I mean, is that still happening, and is it what?
Yeah. So GLP-1s, I think obviously they're here. They're everywhere. Um, and used for so many indications. Dr. Skinder gave a really nice talk recently talking about the story of how ruxolitinib leads to weight gain through the leptin signaling pathway, and then kind of brought it around to the GLP-1s at the end, right? Because we do see this as a common side effect, and this is one way to combat that side effect. In terms of bigger effects, I think the question is unknown, right? So there's a lot of data outside of the MPN world where GLP-1s, obviously in patients who are overweight or patients who have diabetes, it can improve their long-term cardiovascular outcomes. And I know we discussed this earlier, but all that risk is additive, right? And so if we're doing everything we can minimize that cardiovascular risk, you know, we're doing well by our patients. And so I think it is an important part of all that treatment. There's a lot of data with sleep apnea too, right? So say sleep apnea in a patient with PVs also driving their erythrocytosis. If we can better some of that with a GLP-1, I think that's important. I think in terms of like underlying biology, that's still an unknown question, right? A few years ago, there was a lot of interest in metformin because there's thought that somehow the
Name that's
metformin affected,
yeah,
it's kind of long, I would put that in a similar bin. Is there a true biologic effect in a human when we look at it? Or is this something that we just observed in certain cell lines in a petri dish? I think that's the big question. And first foremost are these retrospective analyses, kind of looking at things, large databases of patients who happen to have an MPN who are also on a GLP-1 and what happened to them. And I think that can be certainly hypothesis generating, but certainly isn't definitive. I think for right now, the indications for GLP-1s are what they are, the diabetes, the obesity, the sleep apnea, the cardiovascular risk. And we really kind of hang our hats on that because patients with MPNs have those things, right? And we need to address those to take care of the patient in total.
right.
And I think it's pretty early to say, is it going to be an important therapeutic specifically for patients with NPNs? Um, it could be. It may not. I think we need more information.
Right. So we don't have a lot more time
Yeah.
here, but I always wind up with our physicians and our specialists, and then we do a quick update from our industry partners. But um, what wisdom and what information would you like to impart to the people on this call and on this webinar, and to those that will view this recording in the next few weeks? Um, I can say a million things about the good things that are happening in the MPN community, but what are you seeing? I mean, you kind of mentioned it when you summarized the summer, um, the meetings that you went to this summer, but just as an individual, a physician that goes in,
Mhm.
sees these patients on a regular basis,
Yeah.
what would you share with the people watching today?
It's kind of funny. So I had a patient not too long ago who I saw maybe 3, 4 years ago. They've been taking care, they were seeing their local doc and everything was fine. And they just said, it's been 3, 5 years, somewhere in that range. I need to see you again just to check in, see you. And we're kind of talking about things. I was like, wow, like a lot has changed in a very short period of time. And, we're talking about, well, this person didn't need treatment at the moment. They're still on careful observation, but, you know, they might hit an age where they might need treatment in another decade or so. And we're like, she's like, well, what do we do then? And I was like, I have no idea. Right? So much has changed in the last couple of years. It's hard for me to even imagine. I mean, I would have to be very creative, right? To guess what we might be doing 10 years from now. In fact, that patient we were looking back, like their Jack2 test wasn't even quantified. It was a non-quantified, it was a semi-quantitative. It was like less than 5% allele burden, 5 to 50 or greater than 50. That's all it could do. That's all we had at the time. And that was brand spanking new. And so
Yes.
it's like, wow, we've come this far of like measuring this and understanding it. We still don't have the whole picture, but gee, look how far we've come already. And that, you can only predict that those things are going to continue to happen. So checking in with your doc regularly, having these conversations about what's going on now, what do I anticipate soon, and keeping those touch bases. What we don't want folks is just to disappear into the ether and come back 6 years from now and everything's changed and we haven't kept up on these things. So, although, especially for the low risk patients that are joining us, even if you're just on careful observation, those touch points are really important.
Absolutely, absolutely, and I thank you so much for taking the time to be with us. But you're absolutely right. We hear from new patients constantly. In fact, at every one of our webinars, Dr. Gerds, we have maybe 60 to 80 new MPN patients that come to these, and it's just unbelievable. It is unbelievable. And, we host 20 to 25 a year, so that just blows us away.
Mm,
But we also know we're doing the right thing,
Yeah.
and we
Yeah.
care so deeply about you and your time and all of the docs that share in these conversations with experts. It's so, so important, and we greatly appreciate it, greatly. And
Well, thank you so much, Anne. It's always a pleasure to be with you and everyone who joined us today.
yeah, and we'll see you at ASH, I hope.
Oh yeah, we'll be there.
Briefly,
Yeah.
hopefully briefly and
Yeah.
in a really wonderful
Yeah.
space. And
Absolutely.
thank you. And we are going to move on to our industry partner updates. We have 4 today, and so why don't we do that? We'll start with Insight. And I don't know if Kristen Griffiths is with us. Yep, there she is. Hey, Kristen.
Thank you so much, Anne. I appreciate the time today and hearing from Dr. Gerds. He's incredible. My name is Kristen Griffiths. I'm the Associate Director of Communications and Patient Advocacy for Insight, and I lead programs where we partner on initiatives at Insight that support the MPN community. So happy to be here. Thank you for the time. Insight, so we're a global biopharmaceutical company. We're based in Wilmington, Delaware, and our mission is to solve one for patients. What that means to us is we relentlessly follow the science to find solutions for patients with unmet critical needs, including the MPN community. And today, I just want to take a few minutes. I won't be long. I know there's others that want to present, but I just wanted to mention a couple things about our patient access to products, clinical trials, and then the current programs that we have. So Insight Cares is our patient access program, and we, like to make sure that the patients receive access to the treatments that they're prescribed by their healthcare team. So it is a patient support program. It offers insurance verification, prior authorization support, help with financial assistance programs for eligible patients who qualify. And we always recommend people enroll, even if they don't anticipate needing assistance, because if you're enrolled, you can get assistance that much more quickly. So if you are interested, visit insightcares.com. We spell it INCYTE cares.com. Clinical trials. We are currently enrolling in clinical trials for MPNs. So if you would like to speak to your doctor about information that you see for clinical trials for MPNs, please visit our website, insightclinicaltrials.com. The details will be there, and you can pull that information to talk to your doctor to see if a clinical trial is right for you. And then finally, patient support. We recently launched a program called The Unseen Journey that highlights stories of people living with MPNs. And we utilized generative AI technology to create symptom images using this technology, which is going to be used to help further educate the community about the experience that MPN patients have. So often we hear that MPN patients don't feel seen, and this campaign is an effort to help the symptoms and the patient experiences that you face, raise awareness for it and help you feel more seen. We recently launched an AI tool where you can create your own image of your symptom. They're really incredible images. I highly recommend that you go and try the tool. It's free. You can print the tool out. You can share it with other family or friends, even your doctors. You can share the link, but really, really interesting and a great way to help others understand your experience. So with that, I'll close. Thank you so much for having me. It's such a wonderful opportunity to hear from you and discuss the passion that we have to support this community. So thanks, Anne and team.
Thank you very much. Thank you, Kristen. That was great. Great update. And we'll move on to Leslie Ferber who's the Associate Director of Patient Advocacy at SOBI. Leslie, are you with us? There you are. Hi, Leslie.
Hi, Anne. My internet is a little wonky, so I'm hoping that it will hold out till the end of the
Fine. It's going fine.
perfect. And thank you so much for having meetings like this. As Anne said, my name is Leslie Ferber. I am the advocacy team lead for myelofibrosis. I get to work with organizations such as yours to really amplify the patient voice and create materials to raise awareness. Sobi is a biopharmaceutical company with a clear mission to make innovation care possible for people living with rare and severe diseases such as fibrosis. We know that you oh,
You broke up for a while. Now you're back.
okay. Yeah. So our Sobi's commitment is to support you, the loved ones, and the care team, right? Because we understand it is a team effort. As Dr. Gerds and like I think the whole theme of the meeting is there has been understanding the biology of MPNs, and that just means that it brings new conversations about symptoms, blood counts, genetic mutations, and treatment approaches. So I think this is a great opportunity to really have that. So for SOBI, we have some resources for on-demand education resources. We created a website called InsideMyMF.com. It's an educational website with short videos and just practical resources for you and your loved one living with MF, so you can find, easy to understand information to help you prepare for a doctor's appointment, and then just kind of like key topics that are meaningful that we're hearing from the community as well for you to get more information. And then I think it's no surprise, right? Like patient access is critical and it's so important for patients to have access to the treatment that they're prescribed. So Sobi offers a patient access program as well, where we can verify insurance information, support prior auths, and coordinate with your specialty pharmacies, as well as offering financial assistance options for eligible patients. Thank you so much for your time and opportunity, and for Sobi to really be here to support you through this information and advocacy. So back to you, Anne.
Thank you, Leslie. I appreciate it and appreciate your support. And we'll move on to Pharmacentia and Martin Blood, appropriately named Martin.
Hello. Thanks, Anne, for introducing me. Thank you, Dr. Gerds, for a nice discussion. As Anne said, I'm from Pharma Essentia. Our company is a global company with headquarters in Taipei, Taiwan, and we do have our U.S. headquarters in Burlington, Massachusetts. I am from the medical section of the company, and we do have several trials that we're working on currently. One of them, of which Dr. Gerds had already spoke about, was presented at both ASCO and EHA. It was the SURPASS trial for ET using our product Bezrimi in that patient population. That trial and another trial called Exceed have both completed their enrollments, and the company is currently working on a registrational application to the FDA for the indication of ET for the use of Bezrimi in that patient population. So that's something to look forward to in the coming years. Hopefully that we may have a new indication for our product there. Additionally, we are looking at using Bezrimi in the myelofibrosis space, in the pre-fibrotic myelofibrosis space. There is a trial that will be opening shortly. It's called HOPE PMF. And that trial, if that's something that you're interested in, you would go and speak to your physician about that to find out what sites are available to enroll in that. There is one other trial that's going to be opening probably by the end of the year. However, I don't have the name for that one yet. They haven't named it, but that will be in the PV patient population. So we will have another open trial looking at a different dosing regimen in the PV patients and such. In terms of patient support and advocacy and other things like that, you can find some more information about that on our website, which is at pharmaessentia.com. Like all companies, we do provide patient support for both the drugs and insurance issues like that, and that information can be found on that website. Again, I wanted to thank Anne for her time and everyone for listening to this great discussion.
Thank you, Martin. We appreciate it. And now we will see a familiar face to many of you, Dr. Serge Verstosvik, who's now the Chief Medical Officer at Kartos. Hi, Serge.
Hey, Anne. Hello, everybody. And thank you very much for the opportunity to join today. This is great meeting here. My first time to participate. I'm looking to participate more often.
Yes, I hope so.
Well, Aaron gave us a nice summary of what's happening in the field of MPN, and just reminds me that I actually spent almost 25 years as an investigator working at MD Anderson Cancer Center in Houston, working in myeloproliferative neoplasms, and 2 years ago retired and joined Kartos, a small biotech that is developing, in my view, the most exciting new drug called naftemadlin that can be combined very successfully and boost the response what we get with the JAK inhibitors. Remember, I led from academia development of ruxolitinib and more recently momelotinib. So these drugs really do well on improvement in the symptoms and the spleen, but the response don't last too long. And unfortunately, actually, the response is not very good in too many patients. So unlike JAK inhibitors that inhibit the JAK protein and slow the growth of the malignant cells, the naftemadlin that Kartos has, that's the name of the drug, naftemadlin, inhibits different protein. It's called MDM2, inhibitor of MDM2. And that allows malignant cells to die off. That's what it does. The cells die off. And when it's given together with the JAK inhibitors, it synergizes. So it boosts the spleen response and boosts quality of life improvement. And in addition, improves the biology of the disease. That means improves the fibrosis in the bone marrow, decreases allele burden. There was a lot of discussion about allele burden. The JAK2 mutation number of cells go down, malignant cells go down. The cytokines, the proteins that malignant cells produce in the body of the patients that cause inflammation and symptoms go down. Everything is decreasing as the cells die off. And in clinical studies so far, adding naftemadlin on top of ongoing therapy with the JAK inhibitors showed, in my view, the best and most exciting results so far with any investigational agents. And in part, privately, I can say that's why I joined Kartos. And so where we are at the moment, we are in the midst of doing a phase 3 study to prove that the naftemadlin, when added on top of ruxolitinib, which is standard first-line therapy for patients with myelofibrosis, can actually optimize the care of those patients that have persistent symptoms and persistent spleen. So what I'm talking about, we have a completely novel trial design. Patients with myelofibrosis that have a spleen and symptoms issues are consented and first 5 months treated with ruxolitinib alone. Not everybody needs 2 drugs from the day one. There are patients that do really well with ruxolitinib alone. So after 5 months of looking what happens with the ruxolitinib alone, we then identify patients that have persistent issues with the spleen and symptoms. They are better, but they have still problems. We call them suboptimal responders. Then those patients like that are randomized in a blinded way to receive naftemadlin or placebo on top of ongoing therapy with ruxolitinib to optimize their care from suboptimal to optimal to eliminate that persistent spleen and symptoms if we can in many patients over the next 6 months. So randomization in a blinded way is for 6 months in patients who have a suboptimal response to ruxolitinib. Completely novel design. 250 plus clinical sites around the globe participate in this study, more than 60 in the United States. The name of the company is Kartos with K. The drug is called naftemadlin. It's MDM2 inhibitor. It's a global study, and hopefully this will be the first ever non-JAK inhibitor approved for therapy with patients with myelofibrosis to optimize their care. Thank you, Anne, and everybody for
Great.
listening to me.
Yes, thank you so much, Serge. That was really good. I mean, I'm hopeful, very hopeful. And it looks like great things are happening.
I
Thank,
know. Thank you.
okay, we'll move on to silence and Joe Lors.
Hi, and
Hi,
thanks
Joe.
for having us. I'm Joe Loris. I'm one of the senior directors and medical science liaisons with Silence Therapeutics. Silence Therapeutics is a biotechnology company that was formed in 2005, and it focuses on the discovery and development of novel molecules incorporating short interfering ribonucleic acids. The siRNAs inhibit the expression of specific target genes in hematology, cardiovascular, and rare diseases. Silence is based in London, England, and has a U.S. office in Hoboken, New Jersey. We also have research labs in Berlin, Germany. There are over 120 scientists and research staff at Silence, and we are proud to be a global and diverse company. So why do we call ourselves Silence Therapeutics? RNA interference, or RNAi, involves the use of short interfering RNAs, and siRNAs silences diseases by using the body's own natural mechanism. Our long-acting divesiran compound is an siRNA medication that is designed to reduce the production of TMPRSS6 in the liver, resulting in increased expression of your own natural hepcidin, which is the key regulator of iron homeostasis. By temporarily blocking or silencing the specific gene message, our technology aims to lower the hematocrit, reduce or eliminate phlebotomies, and reduce PV symptoms such as fatigue, brain fog, itchy skin, and lowering the risk of blood clots and strokes. Silence Therapeutics is excited to announce our Sanrico phase 2 clinical study of divesiran treatment. We are currently seeking patients with polycythemia vera who are struggling with excessive phlebotomies or uncontrolled hematocrit levels and want to have a better quality of life. Our phase 2 study is currently evaluating every 6-week and every 12-week sub-Q dosing. If you have had 3 or more phlebotomies in the past 7 months or 5 or more phlebotomies in the past year, you may qualify for our phase 2 study. All Sanrico study sites are now open in the United States, and participants can enroll here in North America. To learn more and find a location near you, please visit www.clinicaltrials.gov. We want to thank Anne, Natalie, and MPN International Advocacy for wonderful work with these MPN specialists, with Dr. Gerds, MPN patients everywhere, and terrific programs like this. Thank you, Anne.
Thanks, Joe, very much. I appreciate it. Good update. Okay, so we are going to leave. We have Dr. Elf coming in on the Thursday, October 16th. She's marvelous. If you've never met her or heard from her, she is she has some very interesting research that she's going to share with us, and that is from 12 to 1 Eastern Standard Time, but you'll be receiving some information about that. Thanks again, and we look forward to seeing you next time.